Listen closely, because what I am about to tell you is the most dangerous kind of false reassurance in all of cardiovascular medicine. A man can run 5 kilometers before breakfast. He can lift weights 3 times a week, sleep well, eat reasonably, and feel genuinely strong. And he can still be carrying a coronary blockage that has been growing in silence for the better part of a decade. That is what makes this so deceptive. The body is extraordinarily good at adapting. It can compensate around a severe narrowing for a very long time, sometimes until the precise moment it can no longer compensate at all. And in some people, symptoms stay completely quiet until the vessel is almost entirely compromised. That is the central point of everything I am going to say today. You can feel healthy and still be sitting on a fragile setup. I am Dr. Zion Adetola, and today I want to walk you through exactly why that happens, which artery you never want to ignore, how plaque actually forms and why it behaves the way it does, why a cardiac event often arrives suddenly in a person who seemed completely fine, and what modern testing can reveal long before a crisis forces the conversation. By the time we are done, you will understand something most people never hear stated clearly enough. Fitness is valuable. It is protective. But it is not the same thing as being safe. Those are two different things, and confusing them is costing people their lives. I want to start with the most misleading sentence in medicine. He seemed fine. That phrase has launched more regret than almost anything else I have seen in clinical practice. A person can have no chest pain, no breathlessness, no obvious warning they can name, and still have a serious problem developing quietly inside the coronary arteries. The body does not always announce danger early. Sometimes it whispers. Sometimes it adapts so efficiently that it says nothing at all. And this is especially true in people who are physically active. Their cardiovascular system compensates. Their heart becomes more mechanically efficient. Their muscles learn to extract oxygen from the bloodstream more effectively. All of that is genuinely good. But here is the problem that nobody explains clearly enough. That same capacity for adaptation can mask disease. A person can run, cycle, complete a full training session, and still have a dangerous plaque growing in the background of the coronary tree. Not because exercise is harmful. Exercise is one of the most protective things a human being can do for their heart. But because symptoms are not a reliable alarm system, they are late, they are inconsistent, and they are particularly quiet in people whose cardiovascular systems have learned to compensate well. This is where people get fooled. They feel strong, so they assume the arteries are clean. That assumption is not safe. And here is the first major idea I want you to carry forward. Risk is not only about how you feel today. Risk is about what has been building in silence for years. Now let me tell you about the artery that cardiologists fear most. The left anterior descending artery, the LAD. People call it the Widowmaker. And that name is not dramatic exaggeration. It is clinical accuracy. The LAD supplies a massive portion of the left ventricle, the main pumping chamber of the heart, the chamber that does the heavy lifting every second of your life. I want you to think of the heart's arterial supply like a tree. The main trunk is not decorative. It is not secondary. It is the structure that keeps everything alive downstream. If the trunk is blocked, the entire system below it is in immediate danger. That is the LAD, not just another branch in the coronary tree. One of the primary supply lines for the territory of the heart that cannot stop working. Not for a minute, not for a moment, Now I need to be precise here, because this is where the standard understanding breaks down for most people. A sudden catastrophic event in the LAD is not always the result of a slow blockage creeping gradually toward complete occlusion over many years. Very often, the real story is faster than that and far more dangerous. And that brings us to the biology of plaque. Let's start at the beginning of the process. Arteries are lined with a delicate inner surface, a thin, smooth layer of cells called the endothelium. High blood pressure, chronically elevated blood sugar, smoking, and inflammatory stress can injure that lining over time. Not dramatically, not all at once. Tiny cracks, tiny irritations, micro injuries repeated again and again across years and decades. The body then attempts to repair the damage. LDL cholesterol, immune cells, and inflammatory signals are all recruited into the repair process. In a sense, the body is doing exactly what it is designed to do, trying to seal a leak. But that repair process can become messy. Instead of a clean, stable patch, you get plaque, a buildup of fat, immune cells, fibrous tissue, and sometimes calcium. The body's attempt to stabilize a problem. That itself becomes a new and potentially greater danger. And here is the part that surprises almost everyone. Most people carry a mental picture of plaque as a simple plug, a substance slowly filling a pipe from the inside, narrowing the opening until blood can no longer get through. That picture is incomplete, and in some of the most dangerous cases, it is completely wrong. Very often, the artery expands outward as plaque accumulates. It stretches to preserve the central opening. It remodels to maintain flow, so blood can continue moving through that vessel relatively normally while disease is advancing inside the arterial wall. You may feel no pain. You may notice no symptom. You may have absolutely no idea that anything is wrong. That outward remodeling, that arterial accommodation, is one of the primary reasons people miss the problem for so long. The vessel is changing profoundly, but it is not announcing those changes with symptoms. So the obvious question becomes this: if the plaque is there, if the vessel has been changing for years, why does the event happen all at once? Why does a person who has been training consistently for years suddenly collapse without warning? Because plaque is not simply about size. It is about stability. Some plaques are hard, calcified, dense. Others are soft, inflamed, lipid-rich, and biologically vulnerable. A vulnerable plaque can behave like a blister under pressure, under the wrong conditions. A surge in blood pressure, a spike in heart rate, a moment of intense physiological demand. It can rupture. When that rupture happens, the body sees exposed material that should not be exposed, and it reacts immediately. The clotting cascade activates. A thrombus, a blood clot, forms rapidly at the site of the rupture, and a vessel that was only partially narrowed, sometimes not even severely, can become suddenly and completely occluded. That is the terrifying mechanism. The event does not always happen because the artery reached complete blockage slowly over many years. It often happens because a fragile, unstable plaque ruptured in a single moment. And that is precisely why people can look completely fine right before a cardiac event. The danger is not always experienced as a gradual worsening. It does not announce itself with escalating symptoms over weeks. Sometimes the trigger is sudden instability, and the first sign is the event itself. Now I need to say something directly about physically active people, because this is a hard truth, and one that is not discussed clearly enough. Athletes are not immune. A person can have a partially narrowed artery and still train hard enough to trigger a crisis. During intense physical exertion, the heart's oxygen demand rises sharply, sometimes dramatically. If supply cannot keep up with that demand, a vulnerable plaque may become the critical weak point. This is the supply-demand mismatch. At rest, the heart may cope entirely adequately. Under significant cardiovascular stress, the system gets exposed, and an active person can sometimes experience a major event with only moderate anatomical narrowing, because the heart suddenly needs far more oxygen than a compromised artery can deliver. This does not mean exercise caused the event. Exercise revealed the hidden limit. The disease was already there. Exercise simply created the conditions under which the fragile system could no longer hold. There is a meaningful distinction between those two things, and understanding that distinction is what this entire video is really about. I also want to separate two different symptom patterns, because this is where people make dangerous and sometimes fatal assumptions. In men, the classic presentation is often pressure or heaviness in the chest, discomfort that may radiate to the arm, the jaw, or the back, accompanied by a clear sense that something is seriously wrong. That is the movie version, and the movie version does sometimes happen. But the real world is considerably messier. In women, the presentation is frequently far less obvious. Unusual fatigue that does not resolve with rest, breathlessness that seems disproportionate to the activity, nausea, a strange generalized weakness, what feels like severe heartburn or indigestion that is slightly different from usual. This matters enormously because people wait for the dramatic version. They wait for the chest-clutching collapse. And while they are waiting, they dismiss the actual signal that is in front of them. Sometimes the warning is not dramatic chest pain. Sometimes it is exhaustion that makes no sense. Sometimes it is shortness of breath on a flight of stairs that you climbed without difficulty 3 months ago. I want to say this clearly and without ambiguity. If you or someone near you experiences sudden chest discomfort, breathlessness, sweating, faintness, or any combination of symptoms that feels genuinely wrong, seek urgent medical attention immediately. Do not try to out-tough your body. Do not wait until tomorrow. That is not caution being excessive. That is the correct response to a potentially time-critical situation. Now let's return to the biology of plaque, because understanding the mechanism gives you power. A plaque is not an innate structure. It is biologically active. It can inflame. It can weaken. It can rupture. The more unstable the plaque, the more dangerous it is, independent of its size. And this is why modern cardiovascular evaluation cannot stop at asking how you feel. The right question is not, how do you feel? The right question is, what is actually happening inside the arterial wall? And that is where proper screening tools become genuinely important. The first tool worth knowing is the coronary artery calcium score, the CAC. This is an imaging scan that identifies calcified plaque within the coronary arteries. Calcified plaque and soft plaque are not the same thing, but a calcium score tells you something critically important, that a disease process has been present, that the artery has already been through a significant process of damage and attempted repair. A meaningful calcium score can help estimate overall plaque burden and inform risk stratification in a way that no blood test or symptom history can match. However, and this is important, Calcium does not tell the complete story. The more immediately dangerous plaque is frequently the soft, non-calcified variety, lipid-rich, inflamed, more likely to rupture. And that is where CT coronary angiography becomes a more powerful tool. CT angiography can show the actual coronary anatomy with a level of detail that was simply not available to clinicians a generation ago. It can reveal narrowing. It can show vessel architecture. And in many cases, it can identify soft plaque that a calcium score alone would not capture. So if someone says, my cholesterol is reasonable and I train consistently, so I am fine, the honest and medically accurate response is this: maybe. But do you actually know what your coronary anatomy looks like? Because maybe is not a plan. And for people in the right risk category, maybe is not a safe place to live. Let me make the plaque story more concrete, because I have found that a visual analogy lands better than a technical explanation alone. Imagine a long hose. The outer wall begins to weaken in one section, but because the inside of the hose has expanded to accommodate the pressure, water still flows. The hose looks functional. Nothing is obviously wrong from the outside. Then, under a sudden increase in pressure, the weakened section tears from the inside. The flow stops instantly. That is far closer to the reality of a vulnerable coronary plaque than the simple pipe narrowing model most people carry. The artery adapts to preserve flow for a long time. The person feels fine, trains hard, performs well. Then the system crosses a threshold. And the heart, unlike a muscle in the leg that can tolerate reduced flow and recover, cannot wait. It has no tolerance for prolonged ischemia. That is why the LAD commands the attention it does. It is not the only important artery in the coronary system. But when it fails, the consequences can be catastrophic because of the sheer volume of heart muscle that depends on it for every beat. Now I want to address a misconception that sounds reasonable but is actually dangerous. Some people reason this way: if there were real plaque in my arteries, I would feel chest pain. I train, I have no chest pain, therefore I do not have a serious problem. That logic is understandable, and it is flawed. Pain is a late and unreliable signal. The artery remodels outward to preserve flow. Collateral circulation can partially compensate for a developing narrowing. The body normalizes an enormous amount of dysfunction before it produces a signal you would describe as dramatic. By the time chest pain is obvious and consistent, the underlying process may already be considerably advanced. This is not because the body is broken. It is because human biology was optimized for survival, not for providing you with a convenient early warning display. A car gives you a check engine light. The human body gives you fatigue, reduced exercise tolerance, vague heaviness on exertion, or very often nothing obvious at all. That is the fundamental difference. And if you want a better data source than symptoms alone, you need objective imaging. Let me now bring in a concept that changes how active people should think about training in the context of this risk: collateral circulation. The heart, particularly in people who have trained consistently over years, can develop backup circulation routes, additional vascular pathways that provide an alternative route for blood flow if a main vessel becomes compromised. Think of them as secondary roads that become progressively more useful if the main road starts to narrow. Zone 2 aerobic training, the kind of sustained, moderate intensity cardiovascular work where you can maintain a conversation but are working steadily. appears to be particularly effective at promoting this vascular adaptation over time. High-intensity interval training, used appropriately and in the right clinical context, may also contribute to better overall vascular efficiency. This is important because collateral vessels can genuinely improve survival of heart muscle in the event that a main vessel becomes compromised. They are not a guarantee. They are not a reason to ignore the primary vessel, but they represent one of the genuine mechanisms through which consistent cardiovascular training confers real biological protection. The lesson is not that every active person has dangerous plaque. The lesson is that training needs to be paired with awareness. You build the backup route, and you keep the main route under appropriate surveillance. Both matter. Now, let me be direct about who needs to take this most seriously. If you are over 45, especially if you are a man, and you have any of the following, this conversation is specifically for you. A family history of early heart disease, blood pressure that has been creeping upward over the past few years, blood sugar that has been running at the high end of normal or has been formally elevated, LDL cholesterol that has not been optimally managed, a history of smoking, even if you stopped years ago, unexplained fatigue or a reduction in your exercise tolerance that you have been attributing to age, any new symptom on exertion that was not there 12 months ago. Do not let general fitness reassure you past the point of clinical common sense. Ask your physician directly whether a coronary calcium score is appropriate for your specific risk profile. Ask whether CT angiography is warranted given your history, your risk factors, and your symptoms. These are not vanity tests. They are not ordered out of anxiety. They are the tools that move the conversation from assumption to reality. And reality, even when it requires action, is always safer than a comfortable fiction. Here is a self-assessment I want you to do right now. Ask yourself these questions honestly. Has my exercise tolerance changed in the past year without a clear explanation? Has my blood pressure been gradually increasing? Has my fasting glucose or HbA1c been drifting upward? Do I have a first-degree relative who had a heart attack before the age of 60? Have I been dismissing breathlessness, unusual fatigue, or mild chest discomfort as just getting older? If you answered yes to more than one of those, that is not a reason to panic. It is a reason to have an informed, specific conversation with your physician. Not a general checkup conversation. A specific directed conversation about coronary risk stratification, about whether imaging is appropriate, and about what your actual vascular biology looks like versus what your fitness level suggests. Those are not always the same story. And when they are not the same story, you want to know early. Let me make this feel real with a specific picture. Two men, same gym, both 57 years old. Both complete the same workout without obvious difficulty. Both look physically capable. One has clean, healthy coronary arteries. The other has a soft lipid-rich plaque sitting in the proximal LAD, partially obstructive, inflamed, biologically vulnerable. You would not know the difference by watching them train. You could not identify the difference by asking how they feel. The second man may have blood pressure that has been creeping upward for 3 years. He may have post-meal glucose readings that spike higher than his fasting level suggests. He may have a father who had a cardiac event at 61 that everyone in the family quietly attributed to stress. He may have been dismissing occasional breathlessness on the last flight of stairs at the end of a long day. He looks fine. His training partner thinks he looks fine. He thinks he looks fine until the wrong morning arrives. That is the trap. And I would rather make this personal before that morning than after it. Here is something I want to address that most people never fully appreciate about the timeline of this disease. A heart attack is almost never the beginning of the disease. It is the visible ending of a long invisible process. That process can exist in people who are disciplined, who train consistently, who eat better than most of the people around them, and who have every reason to believe they have time. Sometimes they do. Sometimes the plaque is stable, the risk is manageable, and a combination of lifestyle and medical intervention is entirely sufficient. But sometimes the plaque is soft, the inflammation is active, and the window between first assessment and necessary intervention is shorter than anyone assumed. The point is not to generate fear. Fear is not a strategy. The point is to stop operating on assumption. A healthy lifestyle lowers risk significantly. Managing blood pressure, blood sugar, LDL, weight, and smoking exposure, all of it matters profoundly. None of it is wasted. But if you want real protection, not assumed protection, not statistically likely protection, but actual knowledge of what is happening inside your specific arteries, you need objective data. That is what CAC scoring and CT coronary angiography provide. Not a guess, a map. And when the risk profile justifies it, that map changes outcomes. Let me give you one practical sentence that I want you to carry out of this video. Do not let a good workout hide a bad artery. Do not let a normal day hide an abnormal trend. Do not let a strong identity as a healthy, capable, active person replace objective clinical assessment when your risk profile calls for it. That is not pessimism. That is discipline applied to the right problem. If you are already doing the fundamentals, exercising consistently, managing blood pressure, controlling blood sugar, maintaining a healthy weight, staying away from smoking, keep doing all of it. Every piece of it matters. None of it is overrated. But if your risk is high enough, add the layer of objective information that can change the entire conversation. That is what informed adults do. They stop relying on hope as a clinical strategy. Here is the complete summary I want you to keep. A person can look healthy, perform well in training, feel energetic and capable, and still have a dangerous plaque developing silently in the coronary arteries. The body adapts around it. The artery accommodates it. Symptoms can be minimal or entirely absent. Then a vulnerable plaque ruptures. A clot forms. A cardiac event unfolds quickly, sometimes catastrophically. That is why the LAD matters. That is why plaque stability, not just plaque size, matters. That is why men and women can show completely different warning patterns, and why recognizing both is critical. And that is why coronary imaging can be worth requesting and worth discussing seriously when the risk profile says it is time. One last thing before I let you go. Remember the people around you. A lot of men over 45 never get properly evaluated because they still feel capable. And capability is mistaken for safety. A lot of women are told their fatigue or breathlessness is just stress or just age. And the actual signal never gets the attention it deserves. Do not let either of those patterns go unchallenged. If someone you care about is in the risk category I have described today, share this with them. And if you are in that category yourself, take the next step. Talk with your physician about your risk factors, your symptoms, if any, and whether a coronary calcium score or CT coronary angiography makes sense for you specifically. That is how you move from assumption to reality. That is how you move from hoping the artery is fine to actually knowing. And in cardiovascular medicine, knowing early is almost always the difference that matters most.